Okay, welcome to the AO Trauma North America Internet Live Pelvic and Acetabular Fracture Management Essentials course. We're pleased and excited to welcome you on behalf of AO North America. So on behalf of myself and the co-chairs, I'm Stephen Sims. I am the Chief of Orthopedic Trauma at Carolinas Medical Center in Charlotte, North Carolina. Dr. Mark Reilly, who is the Chief of Orthopedic Trauma at Rutgers Hospital at Rutgers University and Newark University Hospital, and Dr. David Stephen from Sunnybrook Hospital in Toronto. We welcome you to this course. We will serve as your moderators over the next 8 weeks. At least a couple of us will be on for every session, and we are very excited to proceed with this. So the concept of this internet course, of course, was born out of the COVID pandemic, where our scheduled course had to be canceled, as well as multiple other AO scheduled courses. We modeled this course after several other successful courses that we've seen, which included the osteotomy course, which just completed, which ran successive 9 Saturday mornings. And that's kind of how we will base this course as well. It is set up to be a blended course, which means that we will hopefully have a face-to-face session. Right now, we're looking at probably early January for when that would be. It would be a cadaver session at the Oquenda Center in Las Vegas. And we will be offering CME credit for those people who sign on to watch live. We'll bring your attention to the, if you see at the bottom, this YouTube channel, which is AO Trauma North America. If you go to YouTube and sign onto this channel, you can watch a tremendous amount of video, which would include the video that will be eventually available from this course. This is the outline of the course. It will run 8 successive Saturday mornings beginning at 10 a.m. and it will last 90 minutes for each session. The first one you see here is July the 11th. The first 2 will be the pelvis, and then we'll have a 3rd session that will be an expert panel on the pelvis, and we'll go through some interesting cases. We'll then have 3 weeks going through the various fracture patterns for acetabular fractures. And then we will have a 4th acetabular session, which will be an expert panel session. Then the 8th Saturday will end up with special problems around pelvic and acetabular fractures. So it should be a very good course. One of the beautiful things about doing an internet course is that we didn't have to skimp at all on faculty, because there's really no problem with inviting the absolute best speakers and people with the most experience. And we're really pleased. You can see the slide here with the faculty that we've assembled. And you'll hear from everybody on this page at some point during these next 8 weeks. Would just ask you to make your experience the best. First of all, I would say please bear with the technical challenges that we have, as we all are scattered across North America in various places. I'm sure there'll be some glitches as we work our way through this. Stay engaged. We do want you to ask questions. The questions would be asked on the Q&A questions and answers tab, not through the chat tab. So if you want to ask a question, make sure you go there. We encourage you to ask questions, and we will be giving some ability for you to review the talks that were done today by video. And we'll also be giving some assignments that you can do to look at videos for the upcoming sessions as well. And I think preparing by watching those will make a big difference in how much you get out of the course. And I would say keep an open mind, because there are a lot of different ways to treat a lot of different fractures. And with that, you may find things that are different from what you do, but take that as an opportunity to learn how other people do it. So the first week will be the introduction that we just had. We will have a 15-minute discussion of radiographic evaluation and classification by Dr. Mark Adams from Rutgers Hospital in New Jersey. And then we'll hear from Hans KREDER, who's division chief in Sunnybrook Hospital in New Jersey, on the emergency management and hemorrhage control. And then the remainder of the session will be Dr. Chip Routt from Memorial Hermann Hospital in UT Houston on percutaneous techniques. And he'll go through a very thorough evaluation and treatment plan for how to go about that. So our learning objectives, we want to define the key elements for the initial evaluation, demonstrate the radiology and pelvic fractures, be able to classify the fractures and understand how that affects treatment, and then to be able to go through the techniques and indications of percutaneous fixation. Here are our speakers again today, as you heard, Dr. Mark Adams, Dr. Hans KREDER, and Dr. Chip Routt, all of whom are experts in treatment of pelvic fractures and will give you some incredibly good information in today's talk. Your microphones have all been zoomed. Again, if you have questions, put it under the Q&A tab, not the chat tab, and the moderators will try to answer your questions in that same area, and some of them will be brought through as live questions. So with that, I'd like to introduce our first speaker. It will be Dr. Mark Adams from Rutgers University and University Hospital there. He will be speaking to us on the radiographic evaluation and classification of pelvic ring injuries.
So pelvis radiographic evaluation and classification. When I'm finished with this talk, I would like you to be able to describe what makes for quality pelvic radiographs. On these radiographs, I would like you to be able to visualize the bony structure they represent and describe the relationships between certain bony structures and the adjacent neurovascular structures. There are relevant associated injuries and issues that are apparent on imaging that I would like you to identify. Lastly, I would like you to be able to use the classifications to describe the injury accurately and, as a result, guide treatment and predict associated injuries. The experts that evaluate money to determine whether or not it is counterfeit, when they're in school, they study the intricate details of the real thing, not the fake. Similarly, we will study normal anatomy to start so that the issues that arise from disrupted anatomy become more obvious. When we look at this, we want to be able to picture the skeleton it represents, but also this. In our mind, be able to picture the muscular and neurologic anatomy and their relationship with the bone, as well as the vascular anatomy of the pelvis. Understanding these relationships helps us anticipate injuries to these structures when we examine a radiograph of an injured pelvis. The AP pelvis is generated with the patient in the supine position. The beam naturally is perpendicular to the patient. A well-centered AP pelvis anteriorly consists of symmetric obturator foramina, symmetric teardrops at the bottom of the fossa, a symphysis that is midline with respect to the sacrum. Posteriorly, the spinous processes of the sacrum should be midline, the foramina should be symmetric, and if there is no scoliosis and the patient is lying flat, the similar lumbar spine features are helpful too. In the setting of a pelvic ring injury with deformity, one needs to key in on the posterior structures to know whether or not the film is well-centered. It is difficult to characterize deformity without a well-centered image. The outlet view is an AP of the sacrum, seeing it en face. As such, the foramina are well visualized and circular in appearance. Many of the same characteristics of a well-centered AP pelvis are also applied to the outlet. Let's notice the intimate relationship between the L5 nerve root and the sacral ala. The S1 nerve root is also visible, coursing out laterally from its foramen. The internal iliac and its branches are also in close proximity to the lateral sacral ala, and the median sacral artery is adjacent to the sacral bodies in the midline. More anteriorly, the external iliac courses over the anterior pelvic ring, just medial to that iliopectineal eminence. The inlet view is relatively orthogonal to the outlet, viewing the sacral bodies stacked one on top of the other, and needs to be well-centered and symmetric appearing sacrum. Once again, we see the intimate relationship between the lumbosacral neurologic plexus and the anterior sacrum, as well as the plexus created by the internal iliac branches and the external iliacs descending by the iliopectineal eminence again. Naturally, there is the corresponding venous network here as well. It is important to distinguish the dysmorphic sacrum from the normal sacrum and review some of the radiographic features of dysmorphism. The bottom line, creating this distinction, is that a transsacral screw is possible in the normal sacrum, but not in the dysmorphic. You'll notice that the dysmorphic sacrum has this acute alar slope when compared to the normal sacrum. Furthermore, the upper sacral segment is not as recessed in the pelvis. On the inlet view, we also see a difference at the sacral ala. Radiographically, there is a cortical indentation of the anterior ala on the inlet radiographic view, which is represented with these arrows. To further understand this acute alar slope, we're going to look at the lateral. Note a quality pelvic lateral has overlapping greater sciatic notches and matching iliac cortical densities. This line marks the iliac cortical density. For the osseous fixation pathway and neural tunnel of the first sacral segment of the normal pelvis, I have marked them here. For the osseous fixation pathway and neural tunnel for the first sacral segment in the dysmorphic pelvis, I have marked them here. For the osseous fixation pathway, please note that this does not represent a column of bone that runs uninterrupted from one ilium to the other, like the osseous fixation pathway in the normal pelvis I just outlined. Rather, this pathway is oblique, as we have seen on the inlet and outlet views so far. Furthermore, this osseous fixation pathway in the dysmorphic sacrum cannot run uninterrupted from one ilium to the other, as the majority of this oblique osseous fixation pathway in the dysmorphic pelvis is cranial to that iliac cortical density. In other words, the acute alar slope does not correlate with the iliac cortical density. However, in the normal pelvis, the alar slope corresponds with the iliac cortical density. When we look at the axial CT images of both types of pelvis, we can see that there is an uninterrupted corridor of bone in the normal pelvis that is sizable in width. This same corridor of bone does not exist in the dysmorphic pelvis, however. The posterior line violates the neural tunnels of that first sacral segment. This is why a safe transsacral screw is not possible in the dysmorphic pelvis. Furthermore, with a more anterior starting point, the neurovascular structures anterior to the sacral ala that we just reviewed would be put at risk with a transsacral screw. Chip Routt will further review how to safely execute iliosacral screws later in this session. Now, our natural tendency is to dive into the particulars of the skeletal injury for our patient. But before we do that, our patient's imaging provides a real opportunity to learn about our patient. We're going to go through a few examples just to illustrate this point. The soft tissue window setting on the CT scan can be very helpful, and I encourage you to use it. In this example, not only would this large fibroid complicate work about the anterior pelvic ring, but this large Morel Lavallee has implications for work about the posterior ring. Sometimes our pelvic ring injuries can show up pregnant. Now on this example, our eyes may be drawn to those cam lesions bilaterally, but if you note, this patient has staples, and those indicate that he had a previous laparoscopic hernia repair with mesh. Conversely, this patient has bowel in his scrotum, fatty atrophy about the bilateral gluteus maximus, and the redundant pliable skin common in malnourished patients. This patient has a right sacral fracture, and it is associated with significant osteopenia in the bilateral sacral ala. Furthermore, there are calcifications in her arteries. Believe it or not, this patient is a 25-year-old, but she is diabetic. And based on what we see here, physiologically, she would be comparable to a geriatric patient. In this example, we see the abdominal wall attaching nicely to the ilium, but on this side, we see a traumatic herniation. Here we see a swollen left rectus muscle, a bladder full of contrast, and there's extravasation on the left and extravasation inferiorly as well. These are just a few examples, but by getting to know our patient in this way, we can anticipate problems early and have comprehensive plans as a result. Now, there are three classifications in dealing with the pelvis: the tile, AO, OTA, and the Young and Burgess. These classifications approach the injury from different perspectives. By combining what we learn from each of them, we can engage a patient's injury radiograph thoughtfully and more completely. They will help us describe the injury, organize our thoughts, and guide treatment. The tile classification approaches the pelvic ring from the perspective of stability, breaks it down into 3 categories: stable rings, vertically stable but rotationally unstable, and both rotationally and vertically unstable. In terms of guiding treatment, patients with unstable pelvic rings are indicated for surgery, and those with stable pelvic rings are not. Classification by Young and Burgess is based on the presumed mechanism of injury. From this, we are able to predict associated injuries and resuscitation requirements. The APC injury is a volume expanding injury to the pelvis, tearing that vasculature that we reviewed earlier, and can have significant bleeding as a result. Hans KREDER will go into depth on this next. The lateral compression injuries are associated with head injuries. Now, the OTA-AO classification takes a more anatomic approach to the pelvic ring injury, but also include reference to the type of instability pattern, like in the tile classification, and labels certain examples with the corresponding category in the Young and Burgess classification. A types have an intact posterior arch, B types have an incomplete disruption of the posterior arch, and C types are complete. Thus, there is an increasing amount of instability through the classification. This classification also includes a description of the deformity produced, which helps guide treatment. Whatever the deformity is, it needs to be reversed in order to obtain a reduction. Increasing amounts of instability require increasingly durable fixation constructs to maintain the reduction. Starting with our incomplete injuries, this injury is limited to the symphysis and is rotationally stable as a result. This would be consistent with an Young and Burgess APC 1. Here, the injury extends to the sacroiliac joint, hinging on the posterior ligaments, and the hemipelvis is unstable in external rotation. This is consistent with an APC 2. This sacral fracture is anterior and incomplete, accompanied by an anterior ring injury. This category is rotationally stable and would correspond with an LC1. Here, we have an increasing amount of injury to the sacrum on the bottom image, creating instability. Although this fracture of the ilium illustrated is technically complete, it is classified as a B due to the presumed rotational nature of the injury. Naturally, this hemipelvis will become vertically unstable as well due to unopposed muscular forces. There are bilateral versions of these incomplete posterior ring injuries as well that are in the B category. The C types. Our complete injuries are more severe injuries in the same anatomic locations, with increasing amounts of instability and cranial displacement of the injured hemipelvis. This complete injury to the left SI joint with a symphysis disruption is consistent with an APC 3, and this complete cranially displaced sacral fracture corresponds with a vertical shear. Also in the C category are bilateral injuries with one side complete and the other incomplete, as well as bilateral with both sides complete. Now let's apply these classifications. Here, the anatomic sites of injury are to the symphysis and left sacroiliac joint. It is unilateral, incomplete, unstable in external rotation, and has no vertical instability. For treatment, an internal rotation force is necessary as a reduction maneuver to reverse this deformity. As this is an APC 2, the patient is at risk for bleeding. When we contrast this to the previous patient, we see a major difference at the SI joint. It is cranially displaced, which is obvious when we compare it to the other side, which shows the edge of the posterior ilium caudal to the sacral foramen of the second sacral segment. This means that the injury is complete, and that would be consistent with an APC 3 type. For treatment, not only does this hemipelvis need internal rotation for a reduction, but it needs to be manipulated in a caudal direction. As there is no posterior ligamentous integrity, it would likely require a more substantial fixation construct to maintain the reduction than the previous patient with an incomplete injury. Just to comment on the limits of our classifications. Here is this patient's right hemipelvis. Now, Although it is true that this is a complete injury through the symphysis and SI joint, to characterize this as an APC3 would be inadequate, to say the least. This patient has unilateral injuries to the left sacrum and parasymphyseal ramus, which are incomplete, with internal rotation of the left hemipelvis. Discernment of instability in this injury pattern that warrants operative treatment will be discussed in an upcoming lecture. This is in the LC category, and these patients are at higher risk for head injuries. We see an increasing amount of displacement, deformity, and instability in this patient that was T-bone, creating this lateral compression injury. This is a complete injury to the sacrum that is certainly unstable in internal rotation. When we look at the outlet view, however, we see cranial displacement as well due to the unopposed pull of the iliopsoas. Therefore, this patient's hemipelvis needs to be manipulated in a caudal direction and externally rotated force to reverse this deformity and obtain a reduction. So both a caudal manipulation and external rotation. Conversely, this patient jumped off a 3-story building and has bilateral calcaneus fractures in addition to this pelvic ring injury. This is consistent with a vertical shear mechanism, and we see significant cranial displacement of the right hemipelvis through the complete unilateral right sacral fracture. The L5 nerve was injured as a result, which is understandable given its intimate relationship with the bone. Traction will be necessary to correct this cranial displacement. So in summary, we discussed normal skeletal and neurovascular anatomy in the pelvis and corresponded this to our radiographs. We defined what makes for good views of the pelvis. We went through the comparison of normal and dysmorphic sacrum. There are other relevant associated issues and injuries that can be anticipated on imaging, as we discussed. We then reviewed the 3 classifications from their different perspectives and applied these classifications to several patient examples. This helped us describe the injuries, organize our thoughts, predict associated injuries and issues, and also directed us toward the treatment.
Great. Thank you, Mark. That's a great review of the radiology of the pelvis. That'll be a great lead-in and great foundation for the remainder of the course. As we all know, that some of the difficulty when we talk about instability is deciding what's unstable. We're going to have some good talks on indications. Chip will cover some of those for the percutaneous techniques, and then Brett Christ next Saturday will have a talk on indications for operative treatment of pelvic fractures, which will go through a lot of what you built the foundation for in your talk there. So Sunnybrook Hospital has been one of the mainstays of pelvic education and pelvic fracture treatment for many, many years. It was the home of Marvin Tile. It's where I took my very first pelvic and acetabular fracture course, I think about 30 years ago, when Dr. Tile was in his prime taking care of pelvic and acetabular fractures. So with that, our next speaker is Dr. Hans KREDER, who has served as the Division Chief of Orthopedic Trauma at Sunnybrook Hospital and at the University of Toronto. Has a very vast experience with treatment of injuries around the pelvis and acetabulum, and is going to talk to us about the emergency treatment and hemorrhage control for pelvic ring injuries. So Hans, thank you very much.
Thank you, Steve, and greetings to colleagues that I see have signed on from across the ocean. Good afternoon and good evening to those of you who are joining us from across the way. So what I've been asked to do is to talk about the essentials of the initial management. And at the end of this talk, I'm hoping that you'll be able to understand your role as a trauma surgeon, an orthopedic trauma surgeon, in managing a trauma patient as part of a team, and to perform an emergency assessment of the pelvic ring and to control hemorrhage. We're not going to talk about definitive fixation. That's going to be later on, and Chip will start that after this talk. And to stabilize the pelvis provisionally. And this is all aimed at the early intervention that can hopefully save a life. So looking at this patient who is a 47-year-old crushed in an industrial accident, you can see that pelvic trauma is often extremely high energy. And over the majority of patients who die as a result of blunt trauma had a pelvic ring injury. And the early deaths are due to hemorrhage. And the later deaths, of course, organ failure and sepsis. And what can we do to mitigate this is the substance of the talk that I'm giving right now. And just to start things off, let's start with a little simpler case just to organize our algorithms and our thoughts. So here's a 37-year-old. She's involved in a motorcycle crash, and she's hypotensive. And, you know, what's our role in managing this patient? Well, our role is very simple. It's to look for pelvic bleeding, and when we find it, to deal with it. And so just have a look at that and in your own mind, think of what you think this patient is bleeding from in terms of the pelvis and how you would mitigate that. And we'll start how to look for bleeding. Well, some of you may have thought about looking for external bleeding, but many of you would have thought, well, I'm going to put a sheet on and I'm going to maybe put an Emergent CX fix on or whatever. But don't forget to look for bleeding externally. Bleeding externally has to be sought. Sometimes there's blood all over the place from various other injuries. Look for open wounds in the perineum, the rectum, the vagina, and don't forget to log roll the patient at some point and look for bleeding posteriorly. And although this wound right now looks fairly innocuous, it's just a matter of a clot letting go before it turns into this. So when you see an open wound, pack that wound to stop any bleeding that's ongoing or that may happen as a clot that's sort of tentative there might dissolve and let go. Of course, internal bleeding is what we generally think about when we look at a pelvis that's open like this. This is an APC type of injury. And if it's an open pelvis, it really can't contain the blood. There's no tamponade effect because it just keeps expanding. And you can hide a lot of bleeding in a pelvis that looks like this. So the formula for a sphere is 4/3 pi r cubed, and for a cylinder is r squared h. As the radius of this pelvis increases, you get the square of the amount of blood that can be held in there. You've seen a slide similar to this from from Mark before, and you can imagine that if there's a fracture anywhere in that pelvic ring, and if that pelvic ring is moving around, it's going to bleed. And have another look at this patient of ours. And you can imagine how much disruption of those vasculature, of that vasculature there is. And one of the things that happens when you've got a moving pelvis is it can't form a clot. Things are moving around, you can't form a clot, and it's going to continue to bleed. And just remember that every single pelvis that has an injury is going to bleed to some extent. The majority are going to be venous, but 10% of cases where there's a major contribution from the pelvis to shock is going to be arterial. And these need to be managed maybe a little bit differently. And we'll get back to this further on in this talk. So how do we identify a pelvis that's at risk of major venous bleeding or arterial bleeding? Well, it starts with a physical exam. You've seen some x-rays here, but the basis is the physical examination. So here's a patient, and of course, what we're looking at here as part of the team is the C part of pelvic ring trauma resuscitation in terms of looking for the pelvis that's at risk for internal bleeding after somebody else hopefully has dealt with the airway and the breathing and put in the chest tube and so on. So here's a patient that looks like, in Canada at least, we've got frogs that traverse the highways, and when they get run over, they look like this. And this patient has a very abnormal position, and that's either due to a pelvic ring injury that's opened up, or the proximal femurs or something else is fractured. But if you see an abnormal position like this, that's a pelvis at risk. If the pelvis moves when you examine it, then that's a pelvis that's at risk for bleeding, because again, you're going to have disruption of those vascular structures. And if you've got hematomas in the flank or in the perineum, again, an indication that the soft tissues are torn, and as part of a pelvic ring injury, that this injury is bleeding. So a pelvic ring that's moving and a patient that's in shock, that's an emergency. And you don't have to do anything fancy. You can just tie the knees together, and that's going to help. If the patient has a short leg, or if on a gentle manipulation you feel that the fracture is vertically unstable as well, well, you can apply traction as well. Now, we don't advocate doing an aggressive examination to see if that pelvis moves vertically, because again, you're going to disrupt blood clots and potentially nerve roots as well. But these are the principles. If there's vertical movement, you might want to add traction. Most of you probably use some sort of commercial binder, and the old folks like me prefer the sheets, but they're not really so much available, and the paramedics put these on the field, so we have to deal with them. But if you are one of those places that uses sheets, this is a slide from Routt, and you can see the nice reduction that you're able to get. And the beauty of this is that you can cut holes in for your arteriogram or your angiogram if needed. You can cut holes into this reduced pelvic sheet and put in iliosacral screws or whatever you need. And the general surgeons can usually cut into the top of it and do a laparotomy. But again, it's almost, at least in our center, historical, because everybody comes in with a binder. So what's next? We've recognized the pelvis at risk, at least for venous bleeding. We'll talk about arterial in a minute. And we packed open wounds. We've immobilized the pelvis that moves with either a sheet or binder or traction or a combination. So what's next? Well, continual reassessment is key to managing a trauma patient. And the next stage probably involves doing some imaging. So far, all we've done is a physical exam, and we can do this in minutes in the emergency department. So you've seen a talk from Mark, an excellent talk about radiology, and we certainly won't go through that. But these are the images that we usually want to get when we're planning for the next stage. And one of the things that I think is important to do, especially for the younger learners, is look at this pelvis and just formulate in your mind what's going on. And then bear with me, look at the spinous processes and, you know, sort of think about where the rotation of that pelvis has gone. And you need to explain why this area looks widened here when, you know, this and this look widened here. So having that symmetry and trying to understand why things look the way they do in the front can often lead you to other injuries, as in a simple pubic ramus fracture, high pubic ramus fracture on the left side in this case. Here's a patient who has an AP pelvis, and it looks pretty dramatic, but the way she comes in with the paramedics bringing her in the binder looks like this. So often you can see, if you have the luxury of seeing an injury film in an outside hospital, you can see more of the amount of displacement and the severity of the injury than you may appreciate once the binder or the sheet is in place. You've seen these inlet-outlet views, and this is the inlet view and what to look for, the outlet view. And the CT scan is really important if you're going to do any kind of surgical planning. And you look at this and you might want to know, well, if you're going to do a resuscitation screw, which we'll talk about in a minute, or an urgent fixation with a C-clamp at the back, well, is the other joint open, or is the fracture such that you couldn't possibly safely put a C-clamp or a resuscitation screw without reducing that fracture? So these are important when you're doing the next steps of treatment beyond a sheet and beyond traction. So what are some of those options? Well, here's a case of Dave Stevens that he put the C-clamp on while the patient was having a laparotomy, and this stabilized the pelvis so that the general surgeons could deal with it. So this is one example, the C-clamp, of urgent stabilization beyond a binder and traction. This is a picture of Routt, a very nice picture showing the cut in the sheets and putting a so-called resuscitation screw in. It can be done with the sheet holding the pelvis and then getting a final reduction with the lag screw as you see there. So these are things that can be done urgently if you have the expertise and if you have the equipment available. But you know, this patient could have been kept in the sheet potentially as well. So here's my patient, and you can see there the reduction, pushing the left side, or pulling the left side down and pushing the right side up, and putting an external fixator on through the anterior inferior iliac spines and applying traction on the left side. And you can see the tension sutures there from the laparotomy that the patient had. So what are the corridors, or what types of external fixation can we do? Well, we like the anterior inferior iliac spine corridor, or the supraacetabular corridor. It's a little bit biomechanically better than the iliac wing, and it controls the pelvis, at least in the rotational pelvic deformity, in the plane of displacement. That is, if it's open, an APC type of injury, then it is really in the plane of pulling that together and closing it down. And here are the fluoroscopic views, the obturator outlet view. And with a displaced pelvis, it's difficult because the iliac wing may be open. So again, if you've got a sheet or something that holds the pelvis reduced, it's a little bit easier to get the pin in the right place. This is the supraacetabular corridor, but there's nothing wrong with aiming the pin down into the sciatic buttress or into the area of the sciatic notch, as long as you don't go too far. So the dangers here are if you go too lateral, the lateral femorocutaneous nerve, sensory nerve, the hip joint if you go too low, and it's easier to go too low than you might think. And if you're aiming at the greater sciatic notch, which is fine, just make sure you don't overinsert the pin, and the iliac oblique view is helpful for that. If you use the gluteus medius pillar pins, you have to make sure you're in the bone and in the dense part of the bone. And it's easier than you think to go out the side. And of course, if you're pulling an APC type of pelvis together, that's not going to be very helpful. It's just simply going to break out. So if you are going to err on an APC injury and you're using the gluteus medius pillar pins, you might want to err on bringing it to the inner table so that it's not going to break out as you reduce that pelvis. What else can we do? Well, when should we consider such emergency fixation, or should we just leave the patient in the sheet and traction initially? Well, for us, it's often if the general surgeons are planning a laparotomy, they don't like the binder, they don't like the sheets, so we tend to put on a C-clamp or an external fixator or something like that, and we can do that fairly quickly while they're scrubbing to get ready to do the abdomen. It's better to do it before in most cases, because that way the general surgeons have something stable to work with, but it requires some communication with your general surgical trauma team. And if you're transporting the patient, if you're in a community setting and you're going to transport that patient, maybe it's reasonable to put on a frame or some more provisional fixation rather than just a sheet, but you can certainly transport a patient in a sheet to another institution if needed, and you just have to keep a bit of an eye on the skin. Well, what if you've done all that? You've done the laparotomy, you've put on the C-clamp, you've stabilized the pelvis, and the patient is still in shock, and the general surgeons tell you there's a lot of retroperitoneal bleeding, and you know, what's the next step? Well, if you've gone through this very simple algorithm, if the ring moves, if the pelvic ring moves, you immobilize it, you stop it from moving. Well, if you've done that, then it doesn't move anymore, and you might be in one of these situations where it's an arterial bleed. And we'll talk a little bit about some of the options to deal with arterial bleeds, but one of the most common historically has been an angiography and embolization of said arterial bleed. So here's a patient that I took pictures of when I was a resident. So Mark Veras was the fellow, and Marvin Tile was the staff on call. And this patient came in and had a massive bleed, as you can see on this. This isn't a CT angiogram. This is just an old-fashioned angiogram. And what was remarkable to me as a resident at the time was the buttock hematoma was expanding before our very eyes. And this was a branch of the superior gluteal artery. So if you see an expanding buttock hematoma, that's a sign of some fairly significant serious bleeding. This is the same patient, and you can see the bladder is displaced by that blood on the cystourethrogram. And again, that's a sign of fairly significant bleeding in the other side of the hemipelvis there. And we've talked about, the buttock and perineal hematoma, but this is a different patient, and Dave Stevens written about this and others. If you see a blush on a CT angiogram, that's usually a sign of some fairly significant arterial bleeding. And of course, we're talking here, the most significant hint that you might have an arterial bleed is if you've got a non-responder to immobilizing the pelvis with a sheet or traction or both. Well, one of the things, if you're in the operating room, for example, already, and general surgeons notice retroperitoneal bleeding, one of the options is pelvic packing. And we used to do some of this here at Sunnybrook, and in Denver, this is a very popular thing, and it's somewhat institution dependent. But pelvic packing is putting those large lap sponges in and really trying to occlude the venous, but perhaps also any arterial bleeding that there might be, which means that you're really packing that area quite tightly, that retroperitoneal space. Another option is REBOA, and that includes all of the arteries below where you've got the balloon inflated, except for the collateral flow. Very effective way of eliminating the bleeding, but again, institution dependent. So final thoughts on the emergency management of the pelvic ring that's at risk is it's a team responsibility to warm the patient and give them fluids. You saw earlier on that patient with the externally rotated hips. That patient needs to be covered. They need to be warmed and given warm fluids. And sometimes people forget in the trauma resuscitation frenzy. Your job as an orthopedic trauma surgeon is to pack open wounds, bring the legs together, tie it with a sheet, apply traction if you think so, and that can be done immediately just after doing a physical examination. And then maybe after imaging, you can do external fixation, a resuscitation screw, or some other sort of fixation. And if there's arterial bleeding, if there are positive signs such as we've talked about, or if it's a non-responder, then you've got your options of angiography and embolization, maybe pelvic packing or REBOA, again, depending on your institution. And the important thing is to keep reassessing that patient to make sure that they're improving and that you haven't sort of missed anything. This is a patient that was hit by a subway train, and sometimes you will just fail. The paramedics are bringing in patients from the field now that are very, very extremely injured. And sometimes, despite your best efforts, you will fail. But if you adhere to the principles that we've just talked about, hopefully we'll save some lives that are savable. Thank you very much for your attention.
Thank you, Hans. That's a great talk. I think you hit all the high points there that we need to discuss. So I'm sure there'll be a lot of good questions that come out of that, and we should have a few minutes at the end to try to address some of those that are commonly being asked. Our next speaker is Dr. Chip Routt. Dr. Routt has been a good part of his career at Harborview Hospital in Seattle and has been for the last several years in UT Houston at Memorial Hermann Hospital. Chip has got an incredibly large experience and insight into the treatment of pelvic ring injuries and acetabular fractures, probably one of the largest experiences in the world. He trained many of the faculty that you'll hear speak over the next little bit, and really needs no introduction in this topic. So the next talk will be Dr. Chip Routt, who will speak to us on the indications and techniques for percutaneous fixation around the pelvis.
Thank you, Mark. I'd like to just welcome everyone and give you good greetings from Texas. It's very hot down here, and it's hot from temperature-wise, and we're COVID hot as well. And these are the people that are keeping me safe throughout all of this, and I'm really grateful for their help. This is our orthopedic trauma crew. My task today is to go through percutaneous fixation, and we'll stick mostly to the posterior pelvis as a result of the time, but I'm challenged by presenting to you the indications as well as the contraindications. The osseous fixation pathways in a little bit more detail. They've already been introduced to you. And then I'd like to just go through some of the planning and some of the technical aspects of just taking care of a patient, this patient actually that you see before you, in a fairly urgent manner when she wasn't doing so well. I think y'all understand that closed reduction and percutaneous fixation was born out of just some of the problems that were published in the 80s from the earlier attempts at open reduction. And those have been improved, of course, over the past decade or two, but those things still threaten us. We also realized that this would have been a patient when I was a resident that would have been in the hospital for about 4 to 6 weeks in traction, and then maybe a week or two in a body cast, or a month or two in a body cast. And you can understand that maybe after about an hour and a half in the operating room, as a result of the C-arm and some knowledge of osteology and a little bit of traction, we can make some stab wounds, put some screws in, and on he goes about 3 days later home. A big transformation of care came along with the knowledge of osteology and fluoroscopy and these techniques that we've learned over the past 30 years. Along with the evolution of learning comes issues, and perhaps you can see that this patient's had their symphysis plated. They've had some spine issues, and you can see the guide pin going in for the iliosacral screw on the outlet view, and then you can see on the inlet view that the guide pin has been applied. But it may be the details of some of these things that we're going to go over in the next 30 minutes will alert you when we're through that this is not as safe as it looks. And if you're really keen on what Dr. Mark Adams introduced to you as just some of these osteological details that we see in the imaging, how critical it is, maybe you wouldn't be so surprised to know that the surgeon had an avoidable complication as a result of just not understanding the osteology, though has a fairly significant complication to deal with. So minor little details and understanding of the osteology. Hopefully when you finish in the next 30 minutes, you'll be a little bit more knowledgeable and also motivated to learn some more. We do recognize the daunting nature of this, and really it's just what, when, and how. So let's start with the indications, and then we'll ease on into the contraindications. In reality, you have to have the posterior ring reduced, and so it can be essentially any injury to the posterior ring, a sacral fracture, a sacroiliac injury, a combination injury, but we have to get a reduction. And you can see in this situation, the chances of getting this accurately reduced with a closed reduction are probably about 0. And so we do still use open reduction and then use the percutaneous fixation. Sometimes it's as simple as just taking off the circumferential wrap and applying some traction. And this was a patient of mine from 1994, right after we had gotten cannulated screws. And you could see that we were able to do a nice percutaneous job with 2 stab wounds on her to get her realigned and stabilized quite nicely. So we can do sometimes very simple things to help our patients get reduced and then stabilized. One of the things we learned very early on was that the sacroiliac joint injuries were very different from the sacral fractures. And we realized that the pathology for an iliosacral screw was pretty small or not very lengthy for our sacroiliac injury, but it's different from a standpoint of using the screw, how it starts, where it aims, where it goes, does it avoid the joint, and which way should we insert it and start it and aim it, as opposed to the sacral fracture pathology, which is a little more medial and gives us a larger area of instability for the screw to gain purchase in. And you can see the dotted line represents the now popular transsacral screws that weren't really available until 2006. You may say, well, what was going on before 2006? There weren't screws that were made beyond 130 millimeters in length. And so it took a long time for screws to be long enough for us to be able to use transsacral fixation. Other indications are just any disruption of the posterior pelvic ring that can be reduced and put back. Sometimes we have to redo the ilium in order to just do the iliosacral screws. And then it's not just for adults and elders, it can be for children as well. It's a 3-year-old I took care of about 6 months ago who was inadvertently run over, and you can see that she's 3 years old, but she's got an open pelvic injury that's fairly potentially catastrophic. And you can see the problem that she had. And so people say, well, you know, do you have to use smaller screws? Those are 3-5 screws in the ilium and 7-0 screws in her SI joint. So we can put them back together. A lot of people say, well, children really don't need this because they just, they remodel so well. But you can tell that to some of these patients, like this 9-year-old who was also run over when she was 5 years old. And this is how she's lived for the last 4 years. And with an early open reduction and stable fixation, this would have been a fairly simple fix. But at 5 years later, this is a really difficult situation to negotiate. It also happens in the resuscitation phase. You've seen this already described to you, and this is an example of a patient with some fairly severe injuries, but despite the overall resuscitation, not so good. And then just a patient that we put a hole in the sheets, we can put some towels on, and then we can become a part of this resuscitation effort where we can use a directed iliosacral screw for certain injuries in the back. And as we insert the lag screw, you can see we get a nice compressive reduction of the posterior pelvic ring. If you'll take your attention away from the injured right SI joint and look at the left SI joint, you'll realize that it has some problems as well. And if you were paying attention when we went back to the injury film, you can see now in retrospect both sacroiliac joint injuries have a fairly significant injury to them. And then you can see that in the circumferential wrap, the left side looks pretty good, but then as soon as we compress it, the left side reveals itself. So we can go ahead and just do the same thing on the other side, support the posterior ring and get a nice reduction. Interestingly, usually when you do this, these patients respond to this very well, and within about 5 to 10 minutes, they usually start to plane out very well. So this is a good technique, and it's similar to using a C-clamp, but it's just a more definitive measure. Some of our patients are, we always hear this thing that the patient is too sick for orthopedics, TSFO, too sick for orthopedics, but sometimes they're so sick they need orthopedics, so they're SSTNO. And so we'd like to do early percutaneous fixation and reduction of some of these fairly difficult injuries to help the patient have a stable pelvis and then just get an upright chest so that other injuries and polytrauma can be dealt with. And so sometimes we can do simple maneuvers to manipulate the pelvis, get a reduction, then use percutaneous fixation. And then finally, just this stability issue. I think we all have been taught that if you just close the book, like you can see here in the upper right corner, the sacroiliac joint looks like it's an incomplete injury, should just be able to snap the symphysis back together, plate the symphysis, be okay. But you can see in the operative views, the symphysis has been plated, but the SI joint forgot that it was supposed to be an incomplete injury. In fact, it's a complete injury. So we have to be prepared to use the screws in this situation as well. We also have soft tissue implications where we might want to really do an open reduction, but it's probably not a smart thing to do. And then we have, at least in North America, the rampant obesity, where when we have to use techniques to get the abdomen away from our planned operative field, and sometimes it's only 8 inches deep to the symphysis, and it'd be 20 inches deep to the SI joint. And so we choose to do percutaneous of the posterior pelvic ring after doing the anterior ring open. We also have patients with chronic instability. Oftentimes it's postpartum females. You can see this patient has a residual distraction and chronic instability 5 years after having a child, and we can do the iliosacral screws to help stabilize the posterior pelvic ring. It happens in males as well. This is a man that was injured when he played college baseball 30 years earlier, and he has chronic pelvic instability as well with sacroiliac arthritis. And so it's a good situation for them. And then we have patients that have unusual situations where they have these long spinal instrumentations. They tend to break down their posterior ring. Sometimes, like this patient had infections anteriorly and posteriorly. And once we can control the infections a little bit, we can provide stability. We can also use it for pathological conditions, and not just tumors, but also other pathological conditions. This, of course, is a primary tumor, and we can work with our colleagues in the oncology areas to sort of help provide stability for those. We see the residual of cancer treatment in some of our prostate patients where they've had radiation that was a little bit less than directed. If it's a little bit older radiation, they get radiation necrosis, and they can have U-shaped sacral fractures as a result of this. And then we can see just sometimes the privilege of maturity. As people age and continue to be active, sometimes they'll have bone quality issues. This lady just fell down 3 steps, and you can see she's got a unstable backward Y component, and we can just do percutaneous for that. So the percutaneous is really nice for a lot of different things. And then you can also remember that we'll have patients with acetabular injuries, and we'll get real focused on the left acetabular injury, but then we have to look in the posterior pelvic ring on the other side, and we can see a complete disruption as well. And usually if we get the acetabulum tidied up and the symphysis put back together, we get a nice closed reduction of the contralateral posterior pelvic ring, and we can use iliosacral screws to stabilize that percutaneously. I would say the contraindications are what we said earlier, is when you can't really get the reduction right or your manipulation fails. And so we see a lot of malreduction as a result of people being pretty bullheaded about just doing closed reductions. And so if the closed reduction is not working, or if the injury is not amenable and needs an open reduction, then you have to do an open reduction. You also see people with debris in their tunnels that needs to come out. And then also there are other indications where you just need an open reduction with a closed technique doesn't work. We also want you to realize that just because this body of knowledge is not so new and the evolution has been going on for 30 years, a lot of people are still struggling with this. And so hopefully by the end of this situation, you won't be one of the strugglers that has these wayward screws that cost them a lot of money. Sometimes it hurts the patients and it costs the doctors money. You can see here just some of the randomness to iliosacral screws, all done by people that are pretty experienced. So I'm not able to access the Q&A right now. And so hopefully if there are questions about evolution of learning or indications or contraindications, you can send those through into the QA area. And then if there's something that I need to get to or discuss it, we can do it in the decompression area later. I'm going to switch gears and go from indications and contraindications to the OFPs, and Mark has already alluded to that. And we're going to talk about the osseous fixation pathways. And you know that on the pelvis, there are osseous fixation pathways everywhere. The problem is most of them are curved, and we usually have straight screws so far. And so what we want to try to do is to use a term, we would like to straighten out these curved areas. And this is sort of what we come up with when we look at the pelvic model and superimpose these osseous fixation pathways. And the colored ones are the ones that we use, the red, the yellow, the black, the blue, the white, the green. These are the ones that we use most commonly. And so today we're just going to focus on the posterior pelvic ring, or the iliosacral one. And when I first started doing this, there was a lot of attention to the starting point and where it was in relationship to the posterior ridge on the lateral ilium, the crista glutea. And so we realized that pretty quickly that on just a single axial image, you can have a variety of starting points, and they can all be very safe screws depending on where you aim them and where you stop them. But we can see that the starting point is important, but just like aim and direction and length, they're all important. Everything is important. Simplistically, if you just want to get a better handle on the osteology of the upper sacral segment, it's pretty simple just to think about ellipsoids, tunnels, and cylinders. And if you'll take some cylinders, and if you have a kid, maybe you've got some building blocks at your house, if your child plays with building blocks, and you can stack some cylinders, and then you can add some ellipsoid cubes onto them as well, onto the sides. And imagine where the foramen or these tunnels would be that go back toward the spinal canal that allow the nerve roots to drape over the ellipsoids and through the tunnels. And you can see that the nerve roots are going to go from central, cranial, and posterior in the spinal canal over the ala and through the tunnels to a peripheral caudal anterior area. And so sometimes it's just simplistically stacking cylinders, adding on some ellipsoids, putting in a tunnel, and then you can understand this a little bit more. If you turn it on its side, you can see the cylinders sort of look like the upper sacrum. The ellipsoids have the look of the sacral ala, and then the orange tube shows the pathway of the S1 nerve root, where those nerve roots, again, going from central cranial and posterior to peripheral caudal and anterior. Usually if you look at little kids or young kids or adolescents, they've got the best osteology for lateral sacral imaging. And so if you want to see it better, sometimes the kids have the best look. And you can see this child has a really nice set of osteology, and we can add on our cylinder to one, and we can stack one onto two and understand how those go. And then we can superimpose the ellipsoids where the ala are, and then we can add in and pull away and just look at this to try to understand where these tunnels go relative to where the ellipsoids are, and the tunnel for one and the tunnel for two, and the nerve root of L5, the nerve root through the one tunnel, and the nerve root through the two tunnel. And so we start to see things a little bit differently when we start to superimpose the geometrical figures onto them. You can also sort of circle up the tunnel exit points, the foramen. We call them foramen, but these are just nothing more than tunnel exit points and actually represent a chute rather than a circle. When you look at the 3D modeling, this is the, you know, I really would have given a lot of money, or I would have given probably a finger in donation to have had 3D surface rendered images when I was first learning this. I think y'all's generation is so lucky for so many reasons, and I'm really jealous to the point of almost resentful that I didn't have these three-dimensional surface rendered images. But all that sin confessing, I'm going to just say I'm very happy to still be able to partake in this. And I hope you can see that when you start looking at this modeling, you'll start to see a lot of the things that you really need to see. And hopefully you'll look at them differently after we finish today. I'd also start to alert you to thinking about what you're not seeing on the surface rendered images. And remember, we're talking about these tunnels and these pathways that go through the bone. And then what we're trying to do is correlate it to what we see in the operating room. And so one of the things that might help you is to go back and forth between plain film imaging and the, like this is an outlet image. And you can see that we can start to see what we can see with the modeling, see what we can see by knowing what the anatomy is, and then looking at the imaging that we would see in the operating room and maybe identifying that there are tunnels and pathways and exit points to these tunnels for the upper and second sacral segments. And maybe when we pull that away, when we look at this, you can see it. And when we pull it away, maybe you can see this little lucent spica cast a little bit better than you saw it 30 minutes ago. Mark got into the dysmorphism, and on the upper row here in the unblack background, you can see what we would call a normal osteology. On the bottom row, we see this upper sacral segment, particularly on the far right. If you look at the outlet image, you'll be able to really get an alert as to the dysmorphism off of the outlet images. And if we go in that a little bit deeper, you can see the two side by side, and you can get a clue to these radiographic hallmarks that you'd notice on an outlet view for dysmorphism. I'll just say dysmorphism doesn't mean a thing to anybody unless they're trying to stabilize a posterior pelvic ring injury and get a screw into that conduit of bone safely. So maybe a skeletal radiologist in some remote dark reading room is interested in dysmorphism, but in reality, nobody really cares about dysmorphism except us when we're trying to put screws in them safely. And the patients, of course, care that you know about it also. But we can look at that outlet view on the right side, and we can sort of see that one of the early clues that you can quickly identify is when the L5S1 or the upper sacral lumbar transition disc is at the level of the iliac crest, like you see in the dysmorph. On the normal, or what we call normal, you can see it's recessed relative to the iliac crest. We can also notice that there's a residual disc on the dysmorph, usually reflecting a segmentation error or delay in segmentation. And then we can see also the residual transverse process of that vertebra, as we call them mammillary bodies or mammillary processes, or some people call them just residual transverse process. You can also see the acuity of the alar slope, and it goes from central cranial to peripheral lateral caudal. And you can also see it goes from cranial posterior to caudal anterior. And the acuity of the slope, or the angular nature of the slope, is much greater with the dysmorph. Again, that's going to impact our screws so much. And then, of course, the exit points are misshapen. They're not quite circular all the time for the dysmorphs as they are for what we call the normals. And if you look at the normals, you can see that there's lots of different pathways. As Mark showed you, he's already shown you these pathways at the upper and the second sacral segment in a normal. And then if you look at the dysmorph, it changes a whole lot. You can see, especially in the upper sacral segment, you can do obliques and transsacral for the normal. But at the dysmorph, you've got to really do oblique. And again, that's a caudal posterior start to a cranial anterior endpoint. If we go back to the normal, you can see we can make the oblique screws in the upper sacral segment yellow, or the pathways yellow. We can make the transsacral blue, and we can make the orange at the second sacral segment where it is. And you notice that orange and blue are anterior on the inlet view. If you look in the upper right view, they're anterior. And that anterior location, especially caudally on the upper sacral segment, is where the bone is. That's why we put it there, is where the bone is. On the lateral view, you can see that we can kind of confirm the safety of all of these implants as we put them in. And you can see that the obliquity of the yellow, or the upper sacral segment oblique pathway, that's going to be a little bit tough, because a lot of you like the iliac cortical density to represent where the ala is. And in people who are non-dysmorphic, usually the iliac cortical density will give you a good reflection of where the alar slope is, but it really depends on where you're looking at the point or the end of that screw. If you look at this one, where those screws are ending on the inlet view, you see up the top right, you see the yellow screws are ending in the vertebral body and just barely beyond the midline. But you can understand that those keep it very safe. And so that lateral look of a screw above the ICD in the lower right, you see the screw tip or that pathway is above the ICD, but again, they're staying contained within the vertebral body. If you get a little aggressive and you forget about these limits, remember there's an ala on the other side. And so that oblique look or that lateral look of the oblique screw, it's going to look the same for a screw that's safe, like you see here, focused on the lower right corner. And you'll see that when we extrude through the contralateral ala, the lateral is going to look the same. And if you look above now, you'll see the inlet and the outlet views would look pretty safe to us. Even though the screw is superimposed in the operating room, the screw is going to be superimposed on the bone. And if we forget that high anterior of the alar area has no bone, we would not understand that our screw had extruded beyond the cortical limit on the left side. Again, the caudal anterior location within the osseous fixation pathway, the upper sacral segment of a normal, it's a caudal anterior location. And you can look at this ellipsoid and understand that there is room in a lot of patients that's just a slight bit cranial and posterior to it. But again, the takeoff where the spinal canal enters into the nerve root tunnel, that sometimes will impact that area. So that's a little bit more of a risky screw. I always tell people it's like putting a big fat guy in an elevator. That blue screw, that transsacral screw in the lower anterior corner, if you're filling up an elevator, especially these days with social distancing, you want the biggest guy in the furthest corner so that then you have room to put in others in the elevator. It's the same thing for the transsacral screw in the upper and the sacral in the second sacral segment. We want to put the first screw low and anterior so we have room cranial and posterior. If we go right down the middle and try to optimize our safety, then we're not going to have room for that second screw if we need it. We can also go to the second sacral segment. Again, the low anterior quadrant or the low anterior area in the osseous fixation pathway is an ideal spot for it. And again, some patients like this patient would have room for a second screw at S2 as well. Again, slightly cranial and a little posterior to the first one. As you can see, it's marked there on the inlet, and the outlet is the beige or the white conduit. One of the things that people get in trouble with is they see that white bar or that white tube superimposed on the tunnel of S1 on the outlet image. So if you look at the top left image there, that's an outlet view. And you could see that if that white tube wasn't posteriorly located within the ellipsoid of the ala, it would be in the nerve root. So if it was anterior, if that white tube was anteriorly located, and you can look over to the inlet on the right and see that it's posterior, if it was anterior, it would not be safe. It would be in the tunnel exit area of one. And so I'll draw your attention to these tunnels now. I'd really like you to sort of focus on what you're seeing with the radiology. We see these foramen, or we see these circular areas, and I want to just counsel you that when we're looking at these circular areas, we want to be a little bit more specific and detailed about it, because we want to think about the playground shoot that our kids come sliding out, and we probably all enjoy doing this and come shooting at it. But you can see the tube has an exit point, but then there's a chute that allows the child not to just fall onto the sawdust there. And the bone is just like that in the front of the sacral tunnel. And don't you see the exit point is not just a circle, it's a chute. And so it's just like the playground chutes that we can see. And so we want to think about that when we're doing our outlet imaging. And we want to recognize the spherical openings, but we want to also realize that there are chutes there. So if we put that screw high and anterior, it's not going to be safe at all. It's going to be in that chute and can damage that S1 nerve root. It needs to be posterior, like we show here, like we talked about. So this is all just the normal pathways, and we've gone through this, I think, enough. So if you have questions, please put them in, and we'll get through those related to the osseous fixation pathways of the upper sacral and second sacral segment for the non-dysmorph. I want to just amplify the dysmorph a little bit more because it's so important. And you saw that wayward screw earlier, and we want to recognize on the outlet view on the lower left all of these radiographic markers of dysmorphism that we saw. But in the operating room, one of the critical impacts is the yellow and the white arrows. And I'll call your attention to the right side of the screen, because the white arrows represent the alar anterior cortical limit of the upper sacral segment, the dysmorphic upper sacral segment. And in the operating room, we have to tilt the fluoroscopy on the inlet view appropriately to where we can see the anterior cortical limit of the upper sacral segment, the white arrows, and we can distinguish then the anterior cortical limit of the second sacral segment, because we may want to put a screw there as well. And we want to see the yellow arrows representing the anterior cortical limit of the second sacral segment as well. This is imaging that we can plan preoperatively based on the three-dimensional surface and volume rendered images that we have in front of us, just like I'm doing right here. So I can plan what views are going to give me the discrete osteology limits that I need in order to keep me safe. I know I've got to keep my screw behind the anterior cortical limit of S1 and S2, the upper and the second sacral segments, and I realize I've got to direct the screws obliquely in order to accommodate that at the upper sacral segment. So pay attention to the inlets when you're looking at the surface rendered images, because they're going to help you get the appropriate inlet tilt for S1 and S2 as you're doing these screws, and they're going to reveal to you these alar anterior cortical limits so that you can keep your screws just behind these at these two different levels. So when we look at the upper sacral segment, we've got to do oblique screws, caudal posterior to cranial anterior directed, and we pretty much have to stop in the midline in order to be safe in the upper sacral segment of a dysmorph. In the second sacral segment, you can see we can do transsacral screws, but again, we've got to locate it away from the chute of the upper sacral segment. We can also do oblique screws at the second sacral segment if we want to. I'm not sure many people do that, but from a technical aspect, it is osteologically possible. It's just not probably something that people do too much. I'm not sure I've ever done that screw in my whole life, but I do know that it's possible if I ever would want to do something like that. It's always nice to know stuff, I guess. Now, so again, I just want to recap this dysmorphism, and I want to really alert you to going a little bit cranial and anterior and alert you to that chute. Can't emphasize it enough. So we've now hit the osseous fixation pathways. Hopefully you know about the normal and dysmorph, the outlet, or where we really get the identifiers radiographically to alert us to this. And then those indentations, recognizing the anterior alar limits, that's so important on the inlet. It's just adjusted and customized to fit. And for the upper sacral segment screws, remember we're going caudal to cranial and posterior to anterior in order to accommodate that. And don't forget the chutes. Reductions, I could spend, we could go on reductions for 4 hours, but we're not. We're just going to say that for the posterior pelvic ring and for iliosacral screws and lining up these tubes, it's like a Venn diagram, or like it's like putting tubes together as well, because we've got to put the reduction back. We've got to put the bone fracture fragments back together, or the sacroiliac joint back together in alignment, so that we can make safer screws and we have a improved area for access of our screws, and also for a better outcome of our patient. And we can do whatever it takes. If you're doing closed reduction, you can use traction, wrap up the knees like Hans just showed you, external fixers, universal distractors, clamping through open wounds, circles, working portals in a sheet, sometimes oblique frames. A lot of different things work. So to wrap up, we're just going to go through a planning and just sort of take the patient we showed you earlier with the fairly dramatically displaced left hemipelvis, and we're going to use all of our radiographic clues to help us go through this planning. And so you can see our patient is, she's a 38-year-old female. She's a recovering narcotic addict. She's in the backseat of a car. She's in a rollover motor vehicle accident. She wasn't tossed out, but probably wasn't belted. And she's got some injuries. And you can see a left sacroiliac injury that's fairly complicated and displaced, bilateral pubic ramus fractures, and I would say a fairly significant deformity. And if we look at her volume rendered views, we can get an idea of the amount of displacement that she shows when she's in her circumferential wrap. So the wrap, her pelvic wrap, is really accentuated her deformity, and we can see this pretty dramatically on the inlet view. And you can take things away if that helps you. You can superimpose the surface rendered images on the volume rendered images and adjust the tilt so you can see, and maybe some of you have noticed that she has a left-sided asymmetrical dysmorphism. She had a segmentation error that was mostly on the left side. And then we can also take these three-dimensional, these surface rendered images, and we can correlate in the operating room what we're going to see, and we can magnify these and even superimpose these in our preoperative planning so that we can understand when we're looking in the operating room. I'd like you to be able to see this surface rendered image in your brain when you're looking at these fluoroscopy views, and then things become a little bit clearer. Same thing with the volume rendered outlet. You can see here a hemidysmorphism of the upper segment. I don't even know if that's I don't know what you'd call it. It doesn't matter to me. That's just a place we're probably not going to put a screw, is what I would call it. But you can see it now, and you can see some of the radiographic markers on the outlet. But that next segment, what we would call the normal sacral segment, we can see pretty well. And realize when you're looking at the outlet view in the operating room, that yellow bar represents the cranial limit of the ala, but that's way posterior. It doesn't really give you any indication about the alar slope, especially from posterior to anterior, much less from central to peripheral. So realize what you're looking at are these radiographic lines or these densities that occur, and we're trying to make this thing three-dimensional in our brain. You can also use these surface rendered images like you see on the right to sort of ghost into what you're planning for the operating room as well. And we'd like you again to start seeing these when you're looking at this in the operating room. It'll help you so much if you can see that when you're in the operating room looking at that. So in planning, the axial images become really critical as well, because the axial images are going to give you a lot of information like Dr. Adams has gone over with you. You can see the injury sites in the front and the back. You can see whether there's going to be an opportunity for a transsacral screw. You can see and measure with the PAX machine the length. When we had plain films, there was no way to do this type of planning, but we can know if we have screws that are long enough to accommodate the length, should we be able to get that left-sided posterior pelvic ring reduced. We can also see how the width or the breadth of this conduit, at least on this single axial image, so we know that if we can put a 7mm screw in that, or how many 7mm screws we can fit into that interval. We also can plan on the normal side. If there's a contralateral normal side, we can plan maybe the oblique pathway if we want to, because the normal side is reduced, assuming it's symmetrical. And you can use your eyeballs there to see that that left side, the injured side, that conduit of bone for the iliosacral screw would be a little wider. You'd have an even greater safety on the injured side than you're going to have here. And you can again measure, say, well, it's going to be about an 80mm screw, and I've got 16mm if I go oblique, as opposed to the 11mm that I had if I went transsacral. So when we go transsacral, we complicate things by narrowing those ellipsoids of availability, or that osseous fixation pathway. And then when we go oblique, we improve the safety because it gives us a wider area to go. So a lot of people like oblique screws because they're a safer screw. It's a wider conduit of bone to hit. A lot of people think about these osseous fixation pathways as hourglasses, where the lateral ilium is the base of the hourglass and the waist of the hourglass is where the tunnel and the L5 nerve root are, and then the other part of the hourglass is the other base is where the vertebral body is. And so you can think about it however you want, that gives you the ability to sort of see it in your brain. We also can plan for the second sacral segment, but in this patient, you can see if we don't get a reduction, we got no action going on here. We're going to have a screw that doesn't even get in the unstable part, so we've got to get a reduction. And we can see that it's also much narrower in its breadth than the upper sacral segment. And then we also have to realize that we're much more caudally located and closer to the greater notch, and so we have to start paying attention to where the gluteal trunk is. When we're in the upper sacral segment, usually we're up in the branches of the gluteal tree, the trunk is arborized. And then when we're down here by the greater notch, we're putting the gluteal trunk at risk. So I would also tell you that you and your x-ray tech can plan even things as the obliquity, the lateral cortical surface of where the screw is going to land and where the screw is going to exit if you do a transsacral screw. And that amount of obliquity may vary depending upon which side you're on and how much reduction you get. But you can plan for this and you can sight it and see what that lateral cortical surface looks like so you can get a good image. I like the x-ray techs to also just look at the sagittal imaging so they know what kind of tilt they're going to need in order to stack the cranial two or the upper and second sacral segments. Not always are they like a bamboo pole. Sometimes they've got arthritis at the L5-S1 disc that changes things. But you can see we just got a supine patient here up on a bump, in traction on the left, and then we're just sort of getting our x-ray the way we want to superimpose so we can reliably go there. The tech can mark the machine, mark the floor, and then just go right back and forth between the inlet and the outlet. Again, superimposing the upper symphysis on the S1 area, or the S2 area, so we can see the S1 tunnel exit point. And if you look, this is a non-orthogonal system, and so you can realize that when you make an anterior move like the arrow shows here on the inlet view, you're going to make an inadvertent caudal move on the outlet view. It's always best if these are completely biplanar or orthogonal, but they're not always that way, so we have to adjust. Dr. Graves wrote a paper about that. And again, you can do the screws prone or supine. It doesn't matter to me. You can just plan your inlet and your outlet tilt based on whatever position it is that you like to put the patient in. And then finally, you can take the sagittal image and you can put the cursor in the conduit of bone. Let's just say that we put it right here in this caudal anterior upper sacral segment area. And then we can just scroll from side to side as we go and see if that transsacral screw is even possible in that conduit. Same thing for the cranial posterior one. And then the second sacral segment. You can see that ellipsoid gets a little tight right there. And this is looking just off of the midline area. This is looking out where the tunnels are occurring. You can see the 1 and 2 tunnels occurring in that area. Anyway, lots of planning can happen off of the sagittal by just scrolling on the machine. So we come up with a plan where we're going to have to get a reduction of some sort, and we'd like to use a low anterior yellow transsacral screw at upper sacral segment. We'd like to use the white one, a second one that's a little bit more cranial and posterior within the safe osseous fixation pathway, the upper sacral segment. We probably are going to need an open reduction of the back and the front somehow. That would be our ideal, is to really make this thing as perfect as possible. And that would be our goal. And we can see that's our incision we plan for the front, and then we'll decide how we're going to get to the back. And we may want to go to the second sacral segment if we can get a reduction. The only problem is the patient doesn't read our plan, and our osteological or fluoroscopic plans may not coincide with what's going on. And this patient has an extraperitoneal and intraperitoneal bladder injury, and so she's going to get a long midline laparotomy sort of in an urgent way. And then we're going to meet her this way. They're going to say, it's Saturday at 7 a.m. Can you please come to 28? And as I walk in, the trauma surgeon says, she's kind of sick. If you're going to do something, you know, it'd be really good for her pelvis, but don't do too much. Well, this kind of hurts me because now I'm limited, and I realize she's got an arc line in her groin. She's got a long venous line in her groin as well. She's lost some blood as a result of the laparotomy, and I've been presented with a fairly, I would say not a critically ill patient, but a not well patient. So we're going to stay with the supine. We're going to put her in some traction, put her up on the bump. This is just some folded blankets that we put under the sacrum to elevate them off and keep them balanced to where they're not teeter-tottering. It's got to be wide enough to where it keeps them from teetering. It's got to be long enough to where it sort of supports their sacrum and their entire sacrum and their lumbar spine. Works out just fine. Then we can square them up with a prep and drape. We can prep and drape both sides, and then we can sit down and do the surgery that we want to do, assuming we can get the reduction. Our landmarks, remember, we stacked the upper sacral segment, and we already planned this on the sagittals. We've adjusted, like Dr. KREDER has taught us, to make sure we get down the midline and make sure we've got the C-arm rotated and the patient rotated right. And now we can sort of work on correcting the deformity. And sometimes we can just add traction. And when we add traction, we can restore this arc. And it may not be always exactly the way we want to, but we also have to realize the white stripe represents the intrusion of the articular area of the SI joint as well. And so that's a little bit of a false distractor for us. But this arc is improved as a result of just putting the patient in 10 pounds or 15 pounds of traction. And so you can see we've adjusted this. She's well enough for us to do something, but not much. And so we're going to assess our symmetry on the outlet, like Dr. KREDER's already taught us. The arc of congruity in the front is much better than what we had earlier. And we're going to proceed with our iliosacral screw. We're going to see those tunnel exit points and remember they're chutes. We've planned out where it needs to go. We see the limits to where we are with this little spica cast. We want to be in front of that and above that S1 tunnel, below L5. We've already gone below L5 because we're low and anterior. Again, caudal and anterior, this safe spot for putting the first guy in the elevator. You may say, well, I'd like to have an oblique screw first to do an improved reduction. If I do an oblique screw first, I might get a better reduction if I sort of start at posterior and go caudal to cranial and low to high. I could do that, but I'm worried that I want to get that transsacral fixation, and maybe I'm going to have a crash. I'd rather use a transsacral screw. And so you may want to sort out your planning, how you're going to orient the screws and what your sequencing is going to be. So if you want to do an oblique screw first in order to help with the reduction, and this is going to be its pathway, then you can add in the transsacral screw and see where those screws cross. And you can just mark it, and you see it, the screws would cross on the inlet view. On the inlet view, the screws would have conflict right there on the right side of the mid body. And then on the outlet view, you see they would have conflict out in the alar area. So we know that the screws can be done in sequence and without interfering one another, as long as we position them as we planned. We can't make a real precise plan and then go rogue in the operating room and not be precise, because then we're going to have trouble with our implants. So the plan has to be precise, and then the execution of the plan has to be precise as well. So we opted to just do a transsacral screw. As a result of the situation we were in, we do the inlet, we do the outlet. You can see in the lateral, allows us to see we're not as anterior as we might have thought in the ellipsoid. And then we proceed with our inlet outlets to follow across, and we go through this conduit of bone, just like we planned. That's the yellow dot that we planned preoperatively in the upper sacral segment, the caudal anterior area. And then we realize when we get to this point, we may be wandering a little bit anteriorly. And so we can recorrect with a guide pin, a bent guide pin, just like you do for a femur, to help you recreate or redirect the drill where you'd like to go, and then put the guide pin through. Now comes the time to put the guide pin in, and we're going to put it through the pathway that we prepared, but we're not going to go drilling through the lateral cortex until the guide pin gets right next to it. Then we're going to use this oblique view that we planned on, and we're going to see and feel the guide pin hit it, and then we're going to see and feel the guide pin exit it, and then we're going to be able to have a real accurate depth assessment. And for this patient, we want a little bit of compression, so we have to do a little bit of fast math. So maybe it measures 170 or 130, 150, and we're going to pull a 1.5 centimeters or 2 centimeters off, so that when we put the lag screw in and use this oblique view to see exactly where the washer should land later, before we start to tighten, we want to make sure that we've got it to where the washer doesn't intrude. We like washers because they help us improve the force distribution. And then we want to see if our math was right when we roll on the other side. We want to make sure that we have the right length screw. In this situation, we do an initial lag screw that you can see here in the lower anterior quadrant of the upper sacral segment. We added in then a subsequent fully threaded screw in the more cranial posterior area of S1 that was safe. And then we took the risk of the 9mm conduit and put in the 7mm screw, again, anterior and within the safe area of the screw. And so we're left with a fairly symmetrical pelvis, not so good. We're down the middle as far as the outlet goes. And you can see that if we rotate the patient and get the greater sciatic notches off, like you see the yellow arrow here, we can look down the barrel of our screws. That doesn't really mean much. It just means our screws are probably crooked. If we bring this greater sciatic notches back into alignment, then our screws are a little bit crooked. So for some reason, people love taking pictures of their cannulated screws looking right down the hole in the screw. And I don't know why, especially when it's crooked like this, but so be it. Anyway, when we finish, we want to make sure that we land the screws. We don't intrude the screws. Once the screws intrude, they lose their function. Sometimes, like you can see here, the second screw in the upper sacral segment was a little close to the first washer, so we didn't stack the washers or pancake the washers. We just used it without a washer, and we were careful in landing it. We go to figure out what to do in the front, and you can see the laparotomy is quite low, and then we stress the pelvis in the front, and she has not much movement. We can convert, add a frame, do ORF, whatever it is that you would choose to do. And you can see at the result, we've got a ring reduction that looks like this. We've corrected her deformity on the outlet. And then if you look at her axials, you can see how on the left is her injury CT at the S1 and at the quadrilateral surface. And you can see the symmetry's been somewhat restored. And then the posterior ring is a mess as a result of a lot of things. She's not quite perfectly reduced. And of course, she's got the anterior sacral crush that you see. And then she lived happily ever after, except she's had 3 separate follow-up pelvic CT scans over the last 7 years. This is a patient I did 7 years ago. And she's had 3 subsequent pelvic CTs for abdominal pain for pelvic inflammatory disease. So I've had the ability to follow her on post-operative CT scans for a variety of other ailments that she has that are non-orthopedics. So I'm going to stop, and I appreciate y'all's attention, and I appreciate y'all being a part of this. There's just, again, today we've given you the tip of the iceberg of knowledge regarding these implants and this technique, but hopefully you've got some idea of the indications and contraindications. I would think that you've noticed the pattern through all of the speakers of the osteology and the variety of the upper sacral segment especially, and then how important the radiology is. Radiology is so important to pelvic successful diagnosis and planning and surgery. And then not just the preoperative radiology, but the intraoperative radiology as well, and how those axial and surface rendered and also the sagittal images help so much. And again, we talked about the precision is good from the planning, and it has to be executed as well. And then I like the post-op CT scan just because it allows me to do a lot of post-op critique. And so with that, Steve, I'm going to stop, and I appreciate your attention. And thank you all for letting me be a part of your webinar.
Great, thank you, Chip. That's a huge amount of information to absorb. I'm sure that have been many really good questions. We're a little short on time, so I've asked Mark maybe if he could just assimilate maybe 2 or 3 very common questions from the speakers so far, and maybe we could just answer a couple of those real quick, and then I have just about 5 minutes worth of slides just to wrap up and prepare you for what's upcoming over next week, and how you can review these videos, because I think with the amount of information that was presented, I think a couple of minutes to be able to review through this again would be very helpful for everybody. And then also how you get your CME credit as well. So Mark, is there anything that were burning questions that seem to be repeated that we might could cover quickly?
Yeah, Steve. So there was one that came up a couple of times for Hans to address, or any of the speakers to address, which is, does it seem that REBOA is falling out of favor in terms of hemodynamic resuscitation, or does it still play a significant role in the management of the unstable patient with the unstable pelvis injury?
Well, yeah, so I probably defer to one of my colleagues where REBOA is used commonly at Sunnybrook. We don't really use REBOA in the resuscitation pathway. We have in the past used pelvic packing. I noticed one of the participants was asking about pelvic packing. Pelvic packing needs to be done in the context of a stable pelvis. So, you have to do something else to stabilize the pelvis, or you're just sort of packing something that's going to expand. REBOA has a theoretical advantage of, stopping all the arterial bleeding, but there are some downsides. And again, I defer to some of my colleagues who use REBOA in their practice to answer that question.
Yeah, I would say our institution is used uncommonly, but it is certainly in the pathway. It's usually used with someone that has brisk arterial bleeding. The last one we used was a person who actually came in with a laceration in that area and actually had an external iliac artery bleeding, and they used REBOA up through that in the emergency department. The difficulty with it is it ties up a trauma surgeon for about 10 to 15 minutes while he does that. And if you have a patient who's in extremis, that can be difficult. But it has the same indications as cross-clamping the aorta, basically. And if you can keep it infrarenal, you have a lot less difficulty. If you can leave it in for a very short time, usually if it's used to get the patient to the operating room, and it's someone who's truly in extremis. And then when they're in the operating room, other things are done to stop the bleeding. So I don't know if anybody else has any experience with it.
Yeah, I've seen some really dramatic saves from it that otherwise there's no way they would have survived. And when it's right, it's incredible. And I think sometimes it gets a little bit right now, sometimes overused. It gets used to the point where maybe the patients really aren't so great. But boy, I'll tell you what, I've seen, I bet you 10 patients who would really benefit from it.
So Steve, there were a number of other questions regarding percutaneous fixation. I realize that's going to open a big bag of worms, but to summarize, the questions were typically, when is percutaneous posterior fixation enough? When do you have to add anterior fixation? When do you have to augment your posterior fixation with something else like lumbopelvic fixation or transsacral plating? And if you're relying on posterior percutaneous fixation alone, how many screws does it take to rely on that?
Can you give us a Reader's Digest version of that answer? And we'll probably make that the last question.
I'll just go decade by decade. And so in the 90s, we were just trying to safely insert a single screw in the upper sacral segment, and we were pretty heavy on anterior ring fixation. In the 2000s, then we started using multiple screws at multiple levels, especially when the longer screws came and we could go transsacral. So transsacral became very popular. The good thing about that is we saw failures of fixation not go away, but really go down a lot. Greg Blaisdell wrote a paper and showed the really not the elimination of fixation failures, but a dramatic decrease in doing multiple screws at multiple layers. The trouble you have sometimes with the anterior ring, it can also help the posterior ring so much. Biomechanically, we know that fixing every point of instability is a good thing to do. And so it becomes a clinical stew of what the patient has already had, what the patient can take, how big they are, how old they are, what opportunities you have as far as their overall clinical situation. But ideally, multiple points of fixation, the posterior pelvic ring at multiple levels, and also fixing every part that's unstable is ideal.
Great.
As a final comment, not a question, but next week when we're talking about definitive fixation of pelvic ring injuries, there will be coverage of the question of augmenting posterior ring fixation with open techniques.
And probably a good bit about the order of fixation as well. So we'll try to answer some more of the questions online over the next few minutes, but I think to respect everybody's time and not to try to be over too far on our very first session, which is maybe setting a theme for how we'll probably do throughout this course, we'll just wrap it up real quick. So I just as some take-home points, I think Mark Adams did a great job with the normal bony anatomy and radiographic anatomy. It's critical to understand that that really is the basis for everything we do. As far as fixation goes, examine the entire radiograph, look for soft tissue problems. Classification is important to help guide what we do, and we covered the different classification systems. From Dr. KREDER's talk, again, you want to identify patients that are at risk, and there's a sort of pattern recognition, looking at the exam and the radiographs, recognize those people that are going to have problems early. You need to be involved in the process. The idea is to keep the patient warm, resuscitate them with blood and fluids, and then to stop the bleeding. And there are things this is where we really can be helpful. We stabilize the pelvis, and we talked about the different ways to do that with sheets, binders, external fixators in different positions, C-clamps, and even sometimes percutaneous fixation, or even sometimes open reductions. Angiography and pelvic packing have their place, and Reboa, I think, still does have a place in the treatment of these patients in the appropriate patient. And again, I think the real key is to reassess them continuously, which should be both examining the patient and looking at their lactate and their base deficit to decide how you're doing before you hang it up. And then Chip really gave us some incredible insights into sort of the history and how this process has evolved. And it seems to be somewhat straightforward when he talks about it, but I can tell you that it's been a 30-year learning process to get where we are right now. And you guys are fortunate that you're starting at a point way ahead of where we all started 30 years ago with just trying to figure out what was back there. So be thoughtful about your approach. This is something that requires a good deal of preoperative planning and thought process. Understand the potential bony corridors and the radiographic views and the limits of those, and think about how to stay out of trouble with this process. So with that, we'll wrap up. There'll be a link that will be sent out after this webinar, so you can apply for your CME. It'll ask you to evaluate the course, and then you'll get a link to how to review these videos as well. So you can actually watch the whole thing again and listen to these talks if you think you may have missed things as they went through. As a homework assignment, we're going to give you some videos. This is a link that, again, will be sent to you, so you don't have to write this down or remember it, but there are several videos that are available on the YouTube channel that you'll get a link to. That will go through some of the approaches, the open approaches that we'll talk about next week. But there also are some videos that go through the percutaneous techniques from a previous course that we had that you can review to kind of review some of the issues that we just talked about, when it'll talk about the other corridors a little bit more as well. So next week, to remind you, this will be more about the pelvis, and it will be really the open reduction techniques, open reduction internal fixation techniques for pelvic fractures. And this will, I think, adjunct very nicely to what we heard today with percutaneous techniques. And as Chip said, there are people that, while everybody would prefer to operate through small incisions, there are people that that's not possible, and that will require open reductions to get them taken care of. And if you spend your life never having done that, then you'll never do it. You'll always be accepting things or getting yourself in trouble by doing something you shouldn't do. So with that, I'll wrap it up. I really appreciate your attention. I appreciate those of you who hung in there to the bitter end, which is really about 400 participants that started out, and we have about 400 now. So we appreciate your attention. I thank the speakers for their hard work in preparing these talks and the amount of information they were able to share with us. So thank you. And with that, we'll sign off and close.